Welcome. My name is Henry Bundy. I'm a health services researcher at Atrium Health Center for Outcomes Research and Evaluation. Atrium Health is a hospital network and a learning health system centered in Charlotte, North Carolina. I will be presenting this poster on behalf of my co-authors listed here, but also on behalf of our community partners and stakeholders of the Bridges for Infant Health Stakeholder Group. The names of the members of the group appear on the last slide of this virtual poster presentation. I'll start with some background. In the United States, racial disparities in infant mortality are persistent, intractable, and overdetermined. Poverty, racism, and a lack of ready access to medical services, all contributing factors to infant mortality, span healthcare and community settings and require multi-sector collaborations to affect lasting change. Here, I'll describe our use of community-based participatory research, Cbpr, to identify the racialized barriers to infant health in Mecklenburg County, North Carolina. Our study was conducted in the catchment area of our integrated hospital system in North Carolina, a state that has historically had one of the nation's highest rates of infant mortality. In 2019, the most recent CDC accounting, North Carolina ranked 38th in infant mortality, despite recording one of the lowest rates of infant death the state had ever seen. Mecklenburg County includes Charlotte, the largest city in North Carolina. Here, 1 in 5 mothers report inadequate prenatal care, and Black infants are twice as likely as white infants to be born preterm. We conducted semi-structured qualitative interviews with county patients, providers, stakeholders, and administrators to understand the perinatal care experience of Black mothers in the county. These included 10 key informant interviews with mothers, women who had identified as Black or African American, who were 18 or older, or who had had a baby within the last 24 months. We also conducted 20 interviews with stakeholders, providers, health administrators, and community members. All the interviews were conducted over the telephone, a precaution taken due to the COVID-19 pandemic. In interviews, participants identified barriers of infant health that span the perinatal period, from preconception to childcare. These barriers trace 3 broad themes. 1, expectant mothers often lacked access to basic care and resources. 2, these same mothers regularly experience disrespect and suspicion during their appointments with providers. And 3, the strategies mothers use to resist or avoid these discriminatory encounters could be injurious in themselves. We provided some representative quotes here to give you a sense of what we heard, quotes that express sentiments that came up over and over again in interviews. I feel like that a lot of the doctors don't listen to us. I feel a lot of doctors feel like we're dramatic. A lot of doctors feel like we don't know what we're talking about. A community stakeholder, an African-American woman, all these quotes come from African-American women, said. A nurse, noting that many mothers were unable to prioritize their own care, said, most of the parents don't make appointments for themselves, she continued, because they're taking care of baby. They have other pressing needs, and I think they just get dropped to the bottom of that list of priorities. Finally, we found that in an effort to avoid discriminatory encounters, Black mothers sometimes deferred care until they were able to see a provider they trusted, which often meant a provider of color. As one doctor noted, and they say, Dr. X, I don't want to see another doctor besides you because you will listen to me. Nobody else will understand. So then their kids go these extra days without being seen because they want to wait and see me. Within that quote is another theme that came up repeatedly, that mothers often didn't feel they were being heard. We discussed our interview data with our stakeholder advisory board. The board was comprised of representatives across multiple domains of expertise: healthcare and social service workers, public health researchers, community stakeholders, lay experts, and administrators. Then we used nominal group technique to create a list of recommendations to address the racialized infant mortality disparities in the county. The technique was employed to encourage and facilitate collective deliberation and cooperative decision-making. These conversations resulted in the journey map you see here. I know it might be a little hard to read in this format, but the gist of it is that reducing local disparities in infant mortality in Mecklenburg County will require meaningful collaboration between health systems and community and social service partners, a focus on improvement across the care continuum, and a commitment to culturally competent, patient-centered care. Recommendations from this project indicate opportunity for immediate steps to achieve this goal. Thank you for your time.